Hello, I'm Ricchetti, Director of the Shoulder Center in the Department of Orthopedic Surgery at the Cleveland Clinic. I'll be presenting this interesting case of management of a complex periprosthetic humeral shaft fracture. This is a 60-year-old female who first presented in September of 2013 after a fall 5 months prior onto her left shoulder and development of a surgical neck fracture non-union. You can see x-rays of the non-union on the right, and her past medical history is significant for being a pack-per-day cigarette smoker, which likely contributed to the fracture non-union. Her examination was notable for limited active function and pain due to this non-union, and we elected to proceed with reverse total shoulder arthroplasty with repair of her tuberosities to the humeral component. At 1 year follow-up, she had very good function and was happy with her result. However, you can see on her 1 year x-rays development of a potential non-union of her tuberosities around this humeral component. She was then lost to follow-up and presented at 6.5 years out from surgery with increasing pain in her shoulder over the last several years, and then development of the acute onset of atraumatic pain and loss of function 2 to 3 weeks prior. She continued to be a pack-per-day cigarette smoker, and her x-rays show evidence of a periprosthetic humeral shaft fracture at the distal stem tip of the humeral prosthesis that likely developed from progressive humeral component loosening and subsequent fracture. Again, her pack-per-day cigarette smoking likely contributed to the poor healing after the initial surgery of her tuberosities and subsequent development of humeral component loosening. Based on these findings, we elected to proceed with revision surgery with the plan for likely revision to a long stem humeral prosthesis and use of a humeral allograft with plate fixation. Intraoperatively, we initially attempted to fix the fracture, but this was of too poor bone quality, and we elected to utilize the native humeral bone as a clamshell around the allograft in order to maintain the native soft tissue attachments of both the deltoid and the pectoralis major. The fibrous tuberosity non-union fragments were excised, and the patient's native rotator cuff was then repaired to the rotator cuff attachments on the proximal humeral allograft, and the junction of the allograft and native bone was stabilized with double plate fixation. You can see postoperative x-rays here of the long humeral component as well as the double plate fixation at the junction of the allograft and native bone. And on these x-rays, we see the clamshell of the native humeral bone proximally in order to maintain the soft tissue attachments of both the pectoralis major tendon and deltoid tendon. Her intraoperative workup for infection was negative with negative OR cultures and negative pathology, and at 1 year follow-up, she shows very good functional result with this proximal humeral allograft prosthetic composite with x-rays showing good incorporation of the allograft to native bone. Thank you.